Hi there, my valued and treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I'm a clinical pharmacist by training and profession. I am the founder of Progressive Pharmacotherapy Consultants, your virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes of pharmacotherapy are very crucial and non-negotiable to us. We seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I urge you to sit back and spare me part of your precious time so that I can share critical, useful tips with you. Welcome to part 3 of our series. So in our first question, according to the 2013 ACC/AHA guidelines on the treatment of blood cholesterol and to reduce atherosclerotic cardiovascular risk in adults, which of the following LDL cholesterol thresholds is an indication of high intensity statin therapy? Is it equal to or above 100? Is it equal to or above 130? Is it equal to or above 190? Or is it D, equal to or above 200? I'll give you 10 seconds to make a rational therapeutic choice. According to me, the correct choice is C. Now, statin therapy should be used as treatment in adults with primary LDL cholesterol above or equal to 190 milligrams per deciliter and an age of over 21 years, unless there is a specific contraindication. High intensity statins should be used in this category. So let's move to question 2. According to same guideline, which of the following medications and dosing regimens is considered moderate statin therapy? Is it atorvastatin 80 milligrams taken orally at bedtime? Or is it lovastatin 20 milligrams taken at bedtime? Or is it simvastatin 40 milligrams taken orally at bedtime? Or is it 40 milligrams of rosuvastatin taken at bedtime? I'll give you 10 seconds to make the correct therapeutic choice. So in my opinion, the correct choice is C. Now, the statins we consider moderate intensity include atorvastatin at a dose of 10 to 20 milligrams. So answer A becomes high intensity. It's a wrong choice. Apart from that, rosuvastatin at a dose of 5 to 10 milligrams is considered moderate intensity. So answer D is incorrect. That is high intensity. Apart from that, simvastatin at a dose of 20 to 40 is considered moderate intensity. Pravastatin at 40 to 80 milligrams orally is considered moderate intensity. Now for lovastatin, 40 milligrams is considered moderate intensity. so 20 would be on the lower side. Then we also have two forms of fluvastatin, either the XL 80 milligrams or the ordinary 40 milligrams taken twice daily. That's considered moderate intensity. Then there is finally pitavastatin. So a dose of 2 to 4 milligrams can be treated as moderate intensity. So simvastatin suits us as the correct answer because the moderate intensity is, falls in the range of 20 to 40. So C is the correct option in this case. Let's move to the next question, which reads, which of the following clinical laboratory tests should be ordered and evaluated if a patient complains of unexpected severe muscle symptoms or fatigue while on statin therapy? Is it total bilirubin, or would it be CPK, or would it be CBC, or would you measure the LFTs? I'll give you 10 seconds to choose the correct option. So I would go for C. Now, high doses of statins can cause myopathy, can cause rhabdomyolysis, both of which manifest as muscular pain, like in this case. Now, CPK should be evaluated if a patient experiences unexplained muscular symptoms while on statins, or if there is fatigue while receiving the same. So that makes answer B correct. Now, in the next question, results from a case control study where those conducting the study assessed whether a drug is associated with a decrease in weight showed odds ratio for weight change of 0.7 with a 95% confidence interval 0.6 to 1.2. So ponder briefly, how best can this data be interpreted? Does it mean the drug increases weight by 30%? The drug decreases weight by 30%? The drug decreases weight by 70%? Or the data is inconclusive as to whether the drug is associated with weight change or not. So I'll give you 10 seconds to make a decision. In my opinion, answer D is correct. Now we know that when the 95% confidence interval spans the null, which is 1, the results may not be significant. So this result would suggest we further look into the p-value to determine the significance of our results. Let's which reads, which of the following medications may increase LDL levels in serum? Would it be lisinopril? Would it be hydrochlorothiazide, diazepam, or would it be paracetamol, acetaminophen? I'll give you 10 seconds to choose from the form. In this case, the correct answer is B. Now, the drugs that are notorious for elevating LDL include diuretics, cyclosporine, glucocorticoids, and amiodarone. So from that list, B suits us best as the correct answer to this question. Let's move to the next, which reads, in the Aristotle Study, the rate of death from any cause was 3.52%. In the apixaban per year versus 3.94, note the two percentages, in the warfarin group. The HR was 0.8 with a confidence, 95% confidence interval between 0.8 to 0.99. Now, which of the following statements is true according to your statistics lectures based on this information? Is it the death rate from any cause was lower in the apixaban group than in the warfarin group? Or is it B, the rate of death for any cause was not significant in the apixaban group versus the warfarin group? Or is it C, warfarin had a significantly lower rate of death compared to apixaban? Or is it D, since there is no p-value, no conclusion can be drawn from the given data? So I'll give you 10 seconds to decide. In my opinion, A is the correct answer. Answer A is correct because the rate of death is significant as indicated by the 95% confidence interval, which doesn't contain the value 1. So it is appropriate to make a statement: the rate of death from any cause was lower in the apixaban group than in the warfarin group. Now, the meaning of 1 in a confidence ratio indicates that the risk reduction in the outcome is the same between the two groups. So answer C is wrong because the rate of death in the warfarin group was slightly higher than the rate in the apixaban group if you compare the two figures of 3.94 versus 3.52 respectively. And answer D is wrong because although there is no p-value listed in the statement above, statistical significance can still be inferred from a 95% confidence interval, which is presented above as 0.8 to 0.99. So let's move in the next question. In the same study, in the Aristotle Study, the rate of primary outcome was 1.27 per year in the apixaban group as compared to 1.6% per year in the warfarin group, with a hazard ratio with the apixaban group being 0.79. Now the 95% confidence interval was 0.66 to 0.95 with a p-value of less than 0.001 for non-inferiority. The primary objective was to determine whether apixaban was non-inferior to warfarin in reducing the rate of strokes, both ischemic and hemorrhagic, or systemic embolism among patients with AFib, and at least one other risk for stroke. So the question is, which of the following statements is true based on the information above? Is it apixaban is superior to warfarin in reducing the rate of stroke or systemic embolism among patients with AFib? Or is it apixaban is as effective as warfarin in reducing the rate of stroke or systemic embolism among patients with AFib? Or is it C, Apixaban is more effective than warfarin in reducing the rate of stroke, but not systemic embolism among the same patients? Or is it D? Apixaban is superior to warfarin in reducing the rate of stroke, but warfarin is non-inferior in reducing systemic embolism among patients with AFib. So I'll give you 10 seconds to make a choice. So in my opinion, the correct answer is B. Now answer A is incorrect because the presented p-value is for non-inferiority, not for superiority. Now based on the given information, no conclusion about superiority can be made. Answer B is correct. The p-value provided is for non-inferiority. It can be concluded that apixaban is effective, is as effective as warfarin in reducing the rate of stroke or systemic embolism among this category of patients. Now answer C is incorrect. Stroke and systemic embolism were combined into one primary outcome in this case for that particular confidence interval. Now, more information is needed to determine which agent did better for the specific type of event, not the two lumped together. Now, answer D also looks incorrect to me because the rate of primary outcome was high in the warfarin group compared to the apixaban group, meaning stroke or systemic embolism occurred more in the warfarin group. Now, for the same reason as with C, these two events are represented as a combined into one primary outcome. So more information would be needed. So let's move to the next question. Joz is a 46-year-old African American male patient with a history of CKD due to radio contrast media. His two average blood pressure readings are 157 systolic, 94 diastolic. The heart rate is 65. His CBC and complete metabolic panel are within normal limits, except for serum creatinine, which is 1.6. So, which of the following is the best way to manage his hypertension according to JNC8? Would it be lifestyle modification, or B, lifestyle modification plus low dose lisinopril 22.5 milligrams orally once a day, or would it be lifestyle modification and low dose amlodipine 2.5 milligrams orally once a day, or would you opt for lifestyle modification plus metoprolol succinate 25 milligrams once daily? I'll give you 10 seconds to make a choice. So in my opinion, B is the correct answer. We are told this is a 46-year-old. So he is less than 60 years old. He's African American and he has CKD. Therefore, his goal BP should be systolic below 140, diastolic below 90. millimeters of mercury. Now, in the population aged above 18 or equal to 18 with CKD, initial or add-on antihypertensive treatment should include an S inhibitor or an ARB to improve renal outcomes. That's why lisinopril proves superior. Now, this applies to all CKD patients with hypertension, regardless of race or diabetes status. It's a grade B recommendation. Now, his heart rate is on the lower end of the normal range, which is supposed to be 60 to 80. So if we opted for metoprolol succinate, it would slow this rate further. That would not be an ideal choice. Would end up with bradycardia worsening. So in my opinion, B is the most ideal. To the next question, which says a 65-year-old Caucasian man with a history of hypertension, hypercholesterolemia, presents to your clinic. Despite him being compliant on his medication and lifestyle changes, his two average BP readings are systolic 167, diastolic 107. The heart rate is 88, and his current medication include valsartan 320 milligrams orally daily, high intensity statin 80 milligrams daily, hydrochlorothiazide 25 milligrams daily, amlodipine 10 milligrams daily. Now his CBC and CMP are within normal limits. So which of the following is the best medication to add on to his regimen? Is it metoprolol succinate 25 milligrams orally once a day? Would you add chlorthalidone 25 milligrams once a day? Would you add lisinopril 40 milligrams orally once a day? Or would you introduce nifedipine 30 milligrams extended release orally once a day? I'll give you 10 seconds to make a choice. Opinion, A would be the correct answer. Now this patient is over the age of 60. He does not have any diabetes or CKD, so his goal BP should be systolic below 150 and diastolic below 90. He is currently taking valsartan, which is an ARB, so he should not receive lisinopril. That makes choice B wrong. There wouldn't be any value addition there, because it doesn't make therapeutic sense to administer both an S inhibitor and an ARB together. We should avoid using the two simultaneously, because we'd end up with a serious hyperkalemia among other conditions. Now this patient is currently taking 3 antihypertensive drugs. Now since a 4th drug is needed, drugs from this class other than thiazide, like diuretics, calcium channel blockers, S inhibitors or ARBs, can be used. The option that fits this description is metoprolol, a beta blocker. So that would be my best choice. Remember, option D is a diuretic and D is a calcium channel blocker. So let's move to the next question. A 37-year-old Caucasian man with no past medical history presents to your clinic. Now his two average BP readings are systolic 146, diastolic 87 with a heart rate of 65. His CBC and CMP are within normal limits. Now which of the following is the best way to manage his hypertension according to JNC8? Would it be lifestyle modification? Would it be lifestyle modification plus amlodipine 2.5? Would it be lifestyle modification only and hydrochlorothiazide 25 milligrams daily? Or are both options B and C appropriate? I'll give you 10 seconds to make a decision. So according to my judgment, answer D is correct. I would go for both. Now this patient is under the age of 60 and is considered a member of the general population since he has no known history and is Caucasian. Now JNC8 doesn't address definitions of hypertension and prehypertension, but defines the threshold for initiating pharmacological therapy. Our medications should be initiated when systolic blood pressure is 140 or higher. For Caucasians, either a thiazide like diuretic, an S inhibitor, an ARB, or a calcium channel blocker should be initiated. So both choices B and C are therefore appropriate as options for initiating therapy. That makes answer D correct in my opinion. So let's move to the next question. In a study where rivaroxaban was compared with enoxaparin to find total VTE following hip replacement surgery, there were a total of 17 VTE incidents out of 1,513 patients in the rivaroxaban group and 57 total VTE incidences out of 1,473 patients in the enoxaparin group. So the question is, what is the relative risk reduction using rivaroxaban over enoxaparin? Is it 17, 57, 71, or 2.7? I'll give you 10 seconds to make a choice. So option C is the correct answer, and I'll let you look at the computation for 5 seconds. In case that is too short for you, I would advise you to rewatch the video at a later stage. So let's move to the next question. In the same study, what is the absolute risk reduction of using rivaroxaban over enoxaparin? Is it 17, 57, 71, or 2.7? I'll give you another 10 seconds to compute the correct value. So the correct answer is D, and below is the computation. I'll give you 10 seconds to digest how I reached the answer 2.7%. So let's move to the next question, which says, which of the following is or are categorical data? Is it age, gender, or is it better or same or worse? Or are both options B and C correct? I'll give you 10 seconds to choose the correct answer. In my opinion, the correct answer is D. Now, categorical data includes ordinal and nominal categories. Age is not categorical because it falls under any continuous number, so it is considered quantitative continuous data. Gender is nominal categorical data. Now the option better, same, worse is also considered ordinal categorical data since it falls in some form of order. So that makes answer D our correct option. Let's move to the next question. It says JBO is a 65-year-old male patient with a past medical history of hypertension, diabetes, hyperlipidemia, and benign prostatic hypertrophy. He comes to the A&E with severe bilateral upper quadrant and epigastric abdominal pain associated with nausea. He has no known drug and food allergies and weighs 80 kilograms. A CT abdomen and pelvis with CT abdomen and pelvis with contrast confirmed advanced pancreatitis. Now he has been on tamsulosin for his BPH, metformin, exenatide for his diabetes, ranitidine for dyspepsia, cholestyramine to bind bile and to lower his cholesterol, losartan to lower his BP. His pertinent labs include lipase of 2,976. His HDL is 29, LDL 79, cholesterol 355, triglycerides 1,751, and the rest are as they are. His WBC is 7.9 times 10 power 3. His vitals are: the respiratory rate is 16, his pulse is 117, he has a temperature of 100.5 degrees Fahrenheit, his BP is 138 systolic, 73 diastolic, and his saturating well, pulse oximetry is 98. So which of the following is the best initial approach for his management of the acute pancreatitis? Should it be early aggressive IV hydration with Ringer's lactate, or with the normal saline, or with dextrose 5, or should you opt for early aggressive oral hydration with electrolyte balanced drink? I'll give you 10 seconds to choose from the 4 options. So I would settle for option A. Aggressive hydration, defined as 250 ml to half a liter per hour of isotonic crystalloid solutions, should be administered to such patients unless cardiovascular or renal comorbidities happen where we need fluid restriction. Now, lactated Ringer's solution may be preferred in this kind of replacement. It appears to be more beneficial resulting in fewer patients developing SIRS compared with those that receive normal saline, according to studies. So, options B, C, and D, in my opinion, are incorrect. So, same patient, I'll skip. The vitals are the same. So the question is, which of the following is or are true regarding antibiotic use in acute pancreatitis like this patient has? Is it antibiotics should be given or administered for extra pancreatic infections? Or is it prophylactic antibiotics should be given to all patients with acute pancreatitis? Or is it antibiotics should be given to patients with sterile necrosis? Or are all the options above true? I'll give you 10 seconds to make a decision. In my opinion, A is the correct answer. Antibiotics should be administered for extra pancreatic infections such as this one, or such as cholangitis, or in catheter-acquired infections, or in cases of bacteremia, urinary tract infections, and pneumonia. Now, routine use of prophylactic antibiotics in patients with severe acute pancreatitis is not recommended according to guidelines. The use of antibiotics in patients with sterile necrosis to prevent the development of infected necrosis is also not recommended in any guidelines. Now, routine use of prophylactic antibiotics in patients with severe acute pancreatitis is not recommended. Thus, options B, C, and D to me appear incorrect. So let's move to the next question. So it's still the same JBO, same vitals, but this time round the question to you is, which of the following drugs that he is on have caused pancreatitis according to reports? Is it exenatide, ranitidine, cholestyramine, or is it all of them? I'll give you 10 seconds to make a choice. Correct answer is D. There have been reports of pancreatitis resulting from the use of all the three. Let's move to the next question. So it's the same results, but this time the question is, which of the following is the most likely cause of his acute pancreatitis? Is it the blood glucose of 380? Is it the triglycerides of 1751? Is it the lipase, or is it the calcium? I'll give you 10 seconds to make a decision. Correct answer is B. Now, in the absence of gallstones or a history of significant alcohol use, a serum triglyceride should be obtained and considered the etiology if it exceeds 1,000, or if the calcium levels in serum are high. Now, this patient's triglyceride level is 1,751, way above the 1,000 mark. Now, primary and secondary hypertriglyceridemia can cause acute pancreatitis. Now, serum lipase has a sensitivity and specificity of acute pancreatitis, and it may rise within 4 to 8 hours of the onset of symptoms. It peaks around about a day later. So in my opinion, that makes answers A, C, and D incorrect. So let's move. Same vitals and results. The question this time round is, what is the first line agent for the prevention of hypertriglyceridemia induced acute pancreatitis? Is it niacin? Would you opt for fibrates? Would you administer insulin or go for statins? I'll give you 10 seconds to make a choice. So the correct answer is B. Now, patients with very high triglycerides, i.e. 500 or more, usually require drug therapy in addition to therapeutic lifestyle changes. Now, fibrates and or niacin are practical first-line choices for this category of patients. Now, the initial goal is to reduce or to decrease the risk of acute pancreatitis, especially if triglyceride levels are above 1,000. Now, fibrate therapy can reduce triglyceride levels by 20 to 50%, whereas nicotinic acid derivatives reduce it to a lower extent, around 15 to 25, according to most forms of literature that are available out there. That makes choice A inferior or incorrect. Now, for patients with triglyceride levels below 500, in whom pharmacological therapy is indicated, it's recommended treatment with statins be a better the choice we take rather than any other agent targeted at reducing triglycerides. That makes statins a wrong choice, and insulin therapy is initiated for acute pancreatitis, so that makes choice C incorrect. So let's move to the next question. Same results. So this time round we are being asked, what is the optimal alternative for treatment of hypertriglyceridemia induced acute pancreatitis? Would it be continuous intravenous infusion of insulin with blood sugar parameters? Would you opt for 5,000 units of heparin sub-Q twice daily, or a short duration of high-dose fenofibrates, or a high dose of statins? I'll give you 10 seconds to choose. So answer A in my choice, my option would be the correct. Remember, the pancreatitis impairs insulin secretion. So answers C and D are incorrect in my opinion, as they are utilized for preventative purposes. If apheresis is unavailable, or if a patient can't tolerate it, or if the patient's serum glucose exceeds 500, a continuous IV infusion of insulin should be initiated. Now, typical IV infusions of regular insulin are initiated at a rate of between 0.1 and 0.3 units per kilo per hour. Now, in patients with blood glucose levels between 150 and 200, IV glucose supplementation with separate 5% dextrose infusion will prevent this patient from going into hypo once the insulin is started. Now, the serum glucose should initially be measured hourly to monitor glucose levels, and the infusion should be adjusted accordingly. So it needs personalized, keen care by the nurse taking care of the patient. Triglyceride levels should be monitored every 12 to 24 hours with adjustments of the insulin PRN. Intravenous insulin should be stopped once these levels are below 500 milligrams per deciliter, which typically occurs within a few days. So heparin use is still controversial according to most clinicians, and it is not recommended. That makes answer B incorrect. So let's move to the next question. Now this time round the question is, the physician orders are to give magnesium sulfate 2 grams IV, potassium chloride 40 milliequivalents diluted in half a liter of normal saline, sodium phosphate 15 millimoles IV, calcium chloride 2 grams IV after dilution in normal saline. So, which of the following electrolytes should not be infused together in the same IV line? So imagine your hospital does not have the Y site. Yeah, so you have one line because you do not want to poke the patient several times. Would it be magnesium sulfate 2 grams IV together with potassium chloride 40 milliequivalents IV? Or would it be sodium phosphate 15 millimoles IV alongside calcium chloride 2 grams IV? Or would it be potassium chloride with calcium chloride? Or would it be magnesium sulfate with calcium chloride? I'll give you 10 seconds to make a choice. So in my opinion, the correct answer is B. The issue here is precipitation. Calcium salts and phosphates are inherently incompatible. They'll form calcium phosphate with a very low solubility that would risk occlusion of blood vessels in your dear patient. Thus, one should never ever infuse sodium phosphate and calcium chloride using the same IV line. If you have to inevitably co-administer them, then one must be flushed properly with normal saline before the other infusion follows. They should never be co-administered concurrently using the same IV line. Let's move to the next question. Same patient. Now this time round, the question is, what is his corrected calcium? Is it 7.36, 8.3, 10, or is it 9.1? I'll give you 10 seconds to make a choice. correct answer is A, and below it is the computation. So I'll give you 6 seconds to go through it. And in case you need more time to digest the calculation, you can review the video at a later stage. So my dear viewer and listener, it was a pleasure imparting knowledge. I hope you gleaned useful tips that will make you more effective as you deliver pharmacotherapy to your dear patients. So if this video helped you in any way, remember to give it a thumbs up and to subscribe to my YouTube channel. I would like to promise you that the best is yet to come, and I would like to thank you sincerely for viewing and listening to me. I hope to interact with you more and more in subsequent series. So I would like to welcome you to ensure you watch part 4, 5 and subsequent parts of our series. Thank you.